I'm an electronics engineer. So, 83 batch. I think we were not born at that time. So, in 83 I graduated. And then I did my master's in ISU, Instrumentation Service. So, that is in 87. And then I did my first startup in 89.
Oh, long before startups were
exactly.
popular.
Then we didn't know what is our startup, what is IP, all this. So that was a very interesting product actually. I used to be a assembly language programmer.
Okay.
In those days, and those days that was the most sought after thing, you know.
That's also
like
the hardest.
Python programming, like that. Those days, assembly language programming, C was something, in those days. So I used to do a lot of work with process control. So I used to write extend BIOS. I would write a lot of device diagrams, that sort of a thing. So all of a sudden we found somebody came to me and said there is something called virus. And in 89, it's supposed to be very fun. It's just the Friday the 13th thing, to just wipe off the entire hard disk, floppy disk, everything, all sorts of things. So then I said, okay, fine. What can be done? And within 2 days, I worked day and night, 48 hours, I came up with that product. Just 48 hours. And that was basically, I extended the BIOS.
So embedded program.
Yeah, it is basically all the DOS has a lot of backdoors.
Yes.
It's built on CPM. Yes. And all the CPM backdoor are there in the DOS. They continue to be there like that. And then memory, everything, is flexible in PC. That's how, PCs are really multi-purpose.
Yes.
So what happens is that the main boot operating system itself, the config.sys and io.sys, these are two main files which get into the system first. That itself is moved around everywhere. So every time you move that fellow, you go on attaching a copy of a virus there. So that was the thing. So the first virus was a boot sector virus, and that was called C-Brain. But then we could see that based on that pattern that there will be 5 viruses like Trojaners. So what I did is I patched all the CPM backdoor. So you try to change the some file which is a DAT file to a COM file or an exe file, we catch it. We don't allow. We ask the user, there's something which is changing. And they don't know, okay, if they're intentionally changing, fine. They can say yes, permission, okay, like that. With warning, we will allow. Otherwise, it's stopped. Then that there is some virus. And then what we do is all those sort of malicious things, we delete it.
So how did you decide to make a company out of that idea?
Yeah. So then what we did is that the virus has become such a big news. In US there is this virus. Now in India also it has come. These are some Pakistani brothers who have written this virus. They have always been notorious. And then we said, okay, fine, we'll do this. And then we made a card, an add-on card to the PC and called it Knox card, like Fort Knox. And we made a company about that.
Okay.
And then my friends, 2 of my friends, they were very entrepreneurial, and those guys took the fun. One of them did a fantastic user interface, all that. So it made it very beautiful. And the other guy, he did marketing.
In the days of DOS, to make beautiful interfaces.
Yeah. It was amazing. That guy, Harsha, today, he's one of those college dropout. Okay. Those days, he didn't do his PO itself, like that. That fellow, he was, the biscuit. He would just do any sort of programming he did, he would do it. So that fellow, he did the UI and all that. Amazing, it was good, very fantastic this one. And then we made this company, and I did not actively, take any role in the company, but I used to get my royalty.
Okay.
I earn money from just royalties itself. So I decided, no, I'll go to IISc and do my PhD now, continue my work. So like that, it was really wonderful.
Your
thing.
first entrepreneurial experience.
Yeah. So then I.
Were you working at that time, or was this?
Yeah, I was working. I was working at several places those days. So I used to work for MS Ramaiah College as an assistant professor, and then first half of the day, and then I used to go to Pina and UV circuits. I would do some work for him. Then in Alsur, another company, I will do some calibration related tools for them, instrumentation and stuff. So like that, and then I would also do a lot of tuitions and all that. Oh, there's
So many
things.
their own company or going to academics.
I'll tell you.
So what is good
After
for
this, what I did after that, I went to my ISA. See, all my entrepreneurial thing or whatever little knowledge I had was all in the hardware, firmware, that sort of a thing. Process control. You give me any, a lot of textile industry, rubber industry, all around Mysore, Bangalore, and Davangere, and all. I used to go and anything they give me, right from an emergency lamp to everything I would service. And over the weekend, long weekends, I would go there and service that with one CRO and come back with a lot of cash.
So
that was the type of thing,
Very
So it was there was like literally anything you give me, I can service, that sort of a thing. Then what happened is that in India, a lot of this hardware, big guys started coming in. Everything was imported, but then what happened, some guys like us, we would do this semi-automatic machines, we make it automatic. Say something which is alarm annunciators, all these sort of most important industrial safety equipment, that was imported at a very, very premium cost. We started making it locally. Just add one 8085 board or Z80 board and convert everything to automatic, that sort of thing. But then what happened? People like ABB and MOOC controls and Siemens and all started getting into this. They got these PLCs, okay, and they started taking all that business. So big guys, when they come, nobody will look at small fellows, right? So I said, okay, now I wanted to do my PhD at IISc, so went in IISc 91 and 94. I said 3.5 years max. That's all I can give for this. I could do that. My work was in high performance computing. Using this Param, all that. That's transmitters and all that. We did all the hardware, everything. Fantastic. And then got out. And 94, I did not go back to academics. I got into industry. That's how I started my corporate life.
Can I ask you what your PhD was on and how it has influenced your thinking?
Yeah, my work was on high performance computing. Basically, it was a MHRD funded project. It was with one professor in the aeronautics engineering. He had this grant. It was around 10-12 lakhs or something like that. And that money, he wanted to spend it on this particular concept of having a national grid. Today we are having in pockets, but the plan was, to have a national grid,
national power grid,
and control that through satellites. So that was the thing. So that way we have, the biggest challenge, in such a thing is, all the transmission, everything happens on high voltage DC. So because it is DC, control is very important. It's real-time controls you need within the half cycle or within 33 milliseconds. Crossover happens, right? Within that time, you have to give controls, and it can be anywhere. The inverter can be in Assam, and then the rectifier is here, in Bangalore. So you can transmit power from anywhere to anywhere. And the problem becomes much more complex when you have multiple such DC links connected together. Because national grid, you have to connect multiple of them. So that's how it becomes the empty DC system. And in MTDC system, your controls have to be really very fast.
So that's why satellite. That's why
Yeah.
satellite.
So my work was to make a flexible or a scalable hardware software, which can scale along with the system as it goes. So I had a hardware system with 5 processors. And application specific processors like a DSP processor. There is also a A to D, D2A converters, and that is another processor. And then for the UI, during development you may want to have a UI interface. So the same architecture, you just plug in this additional thing, then it becomes a development system. If when you are deploying it, you can take it out. So these sort of clusters of 5 processor systems, you can go on, for 4 terminals, you have one. So that, you can go on scaling. So I had to prove that both the software and hardware is scalable. And you can still get the same real-time performance.
And if I can ask you, of course, PhD requires a different level of commitment, and also it requires a research thinking, orientation. As you think that has influenced you in the years after that?
Certainly. See, the whole concept of how we can take a small little system and make it, to a large one. Like for example, we are talking about a TC link between Tamil Nadu and Karnataka. It's a small little thing, that sort of a link. Control is easy. Now, if you want to make it a 10 by 10 system or a bigger system and spanning across geography, then you need to see now how this same concept, like what we do in code reuse and all that, right? Like that, how the entire module concept can be extended. Yeah, that was the main thinking process. If you see anything for that matter, maybe a simple Ola, Uber or Zomato or whatever, everywhere it is the same thing, Then you have a sort of a grid computing, or like, you have a cloud-based system. Cloud-based system is again nothing but it's a parallel processing system. Okay, so you have a resource grid here. Okay, you have storage and computation, resource grid. So the same concept, is actually going on becoming, bigger and bigger. The only thing what we see, the difference is that it is more of this homogeneous system. Whereas earlier, when we had the Cray or the computer that is Param and all these, it was sort of heterogeneous. So that way, this concept of how you develop something which is modular and scalable is something which we day in and day out, try to apply for everything. Now for healthcare, I'm trying to apply that. And I'm seeing, how we can solve big problems by first making them, simple and small. And then, you can start expanding it in the week.
Modularity and repeatability.
Exactly.
Okay.
Modularity, repeatability.
It's nearly decomposable systems.
Exactly.
Like Herbert Simon.
Yeah. So that's a very important aspect, and that's what we see, in every walk of life. And see, that is how it can scale up so fast. If you see today's industry, like earlier days, if you see, IBM or HP, they had their huge, gigantic machines. Okay, and yeah, well, these are all having certain capacity. After that, it runs out of its capacity, and it's a good business also. Okay, they'll buy one more. People who have grown to that level have the money to buy many more, right? But it becomes totally unaffordable for people like, in India.
Yeah.
A company in India can't afford that. Very few, have these mainframes and all these big gigantic machines.
Then you can have these commodity machines that...
Yeah, but now if you see, the moment the PCs came in and all that, and you could see that, it's this entire power of computing came into the hands of even small people, right? And then start to grow like anything. And that's how we if we didn't have this PCs, for example. I don't think India would have become software giant, software leader.
Can I ask you a little bit about the period after that when you went into corporate culture?
Yeah. So then what happened? Like I was with CG Smith Software. That was a very good company, and we had a very good leader. And what we don't generally, in academic world, what we don't spend much time is on regulatory, standardization, quality. Or means not that we don't do good quality work, but we don't have that documentation, patience, and all that, right? So this was something I could learn, in this CG Smith, and that the importance of that as to why you need all these like standard processes, and then it was a CMM level 5 company. And the guru, who made the CMM level 5, the second company in the world, to get CMM level 5 was Motorola. And that was led by George Smith. And George started this CG Smith. So I had a great opportunity to work with that type of people. And that was something, which I really I could appreciate and see. Then soon, what happened is that, with the IISc degree and this sort of experience, even though it was short experience with big leaders like George, immediately, I got an opportunity to set up an R&D center for a multinational in India.
Wow.
Ericsson wanted to start their R&D in India.
You must have been quite young at that time.
Yeah. So I had the opportunity to start that R&D right from getting the TPI registration and all that. Today it is very easy, but those days it was a lot of process involved in that. And all that we got, even the building, got the place also on MG Road. We had our office, Prestige Meridian, the dark building, Prestige Meridian. And that was another experience.
So how did you compare the entrepreneurial, slightly chaotic setting before the ISC to these two companies after that?
See, that is a thing which people not to boast of IISc, but what we see is our training in IISc will really make it easy. And see, there is one thing what we see is we see our seniors, we see the type of faculty we have there, and all that that makes it very clear that there is nothing we cannot do. Okay, that's sort of a immense confidence. you start building, and then when you are applying that, we could clearly say that this guy if 100 people are there, later on I worked for Tata, I was in TCS for around a year or so. I could clearly say, the 600 people working in embedded system, I could say that, this guy is from IIT or IISc compared to somebody else. That way there is a huge difference, in the confidence and in the knowledge, what they would have acquired and the type of training and all that. So that makes us successful very, very good. And then I went to the head office of Ericsson. I was expatriate there, and I was in Sweden. I worked there for 3 years, directly with the CTO of Ericsson, and those sort of guys. Amazing, that their work culture.
Directly under the CTO?
Yeah. I was a strategic product manager for a business line. So it was, and then that gave me exposure to how big corporates are. How do you make a roadmap?
I think that time Ericsson was one of the leaders in mobile telephony.
Exactly. Even today, in the back end network, that is the base stations and all that, still Ericsson is leader. So mobile networks, we were all very strong. We were the first to come up with the GPRS. And then, I had the opportunity to see how we can make some business out of data networks. Because now, you have all seen, how much business that can make. But imagine the days when phone was predominantly for voice. And there was something called SMS. And it was always free. Because SMS was not on the traffic channel. It was on the signaling channel. So it was free. and it used to be small text, right? So that was not be a big bandwidth. Now you have made in 2.5G, we say, you have added something called the data layer. That's the GPRS. And now, if you go to people and say, hey, this has data capability, like SMS, you can have many more. They'll think that, I'll get many more services for free. How do you sell that?
Yeah.
So, what value will they be in a position to attach to it? So, that is the thing. So, that's where, we started to work with healthcare.
Okay.
That was how I got introduced to a little bit of this healthcare. So, we said home healthcare those days. That's in 99. You're talking about home healthcare. And you're talking about monitoring the patient in real time. Cardiac patients.
Long before others were looking at it.
Exactly. And we work with some of these places like Karolinska Medical Research Center, which is one of the best medical centers in the world. There is, in fact, the place where Nobel laureate for medicine that will be decided in that institute, that sort of an institute. So, got an opportunity to work with such esteemed institutes, and we did this experimentation. So, people with cardiac procedures like bypass surgeries, they would be, staying in a ICU, that is cardiac care units, for a few days, like a week or so, and then they will be shifted to a cardiac care center. A step down ICU. It will be normally another building or something, and they will be monitored for 3 months. That was the standard those days. Because within 3 months, if they get another attack or something, then they cannot do a bypass on them again. Not really. So normally that will be fatal. So that's why they have to be monitored. So that is a huge cost. Imagine, and that in the Western world. So we said that they can now go home. And we can remotely monitor them on GPRS network.
Okay.
So we put 50 patients on a trial and all that. That was amazing. And it was so nice to hear to these people. What used to take 3 months for them to recover, to become fully fit for fun, it could be done in 1 month. Can you imagine? It's more psychological.
They're home.
Yeah, they're home.
Right.
And they used to say, oh, fantastic,
They feel normal when
I can do gardening.
Right.
Okay. I didn't know that gardening is such a nice hobby until I heard this feedback. They said, oh, I can now do my gardening and I can stay at home. That was the thing. So that way, it's a huge shift. And the cost you should see. Normally, 60 to 70% of all healthcare costs are institutional costs. Means the hospital is in a big place. There is a lot of this one, whether it is an ICU or it is this one, whichever ward it is, there is a minimum level of hygiene to be maintained. There are people coming in and going out, so you have to keep on cleaning. All these expenses, are very high. And the chances of infection is like if there are outside people coming in, even if it is 1 or 2 also, infection can happen.
Yes.
So that way. Whereas when they are at home, there is nobody coming. That too in a country like Sweden, I know that nobody comes just like that.
So real breakthrough.
So there was a lot of reduction in those costs. So these are the things, like technology is simple. Okay, GPRS technology, fine. You put one variable 5-lead ECG or 3-lead ECG. That's technology-wise, it's very, very simple. But the thing is, how you get business value out of it, and how you increase the customer satisfaction, and these sort of things are something which we start. Then what we learnt is that the home hospital concept. This was a European Union project. It was the 8th framework project or something like that. And even your company might have been blessed with money. Still, if it is a government project, if it is a sort of a, now what we see grants and all, nowadays it's everybody want to participate. But I did not have any clue of these things. Even though my PhD work was with a grant, it was like, okay, IASC, you will get this, that sort of thing. But it was not like, there's a competition, the international level competition and all that. Whereas that is something we saw in the European Union project. There is Ericsson participating, Nokia participating, everyone participating in that, everyone bidding for a proposal, making a nice proposal, get the money, and then you do the project, with 20 partners, 30 partners, that sort of thing. So that was something, which I really, that was eye-opener. It was
Do you find such government projects or participation, especially in newer areas, in India also? Government involvement?
Now there is a lot of things happening, and DBT is doing an extremely good job there.
Big and the Virat.
There's so many programs with DBT now. There's a National Biopharma Initiative and so many other things which have started newer programs. Amazing. There is now a lot of and DST of course has its own programs. It has its right from STEP. It has all the Techno Entrepreneurship program to it has a program like Technology Development Board, various programs. Now, there is a lot. And then, these are again, now we have these bilateral programs with several countries, almost all the countries, all the developed countries, I should say. Indo-French, Indo-German, Indo-Europe, all sorts of things. So that way, jointly, it encourages you to Indo-Canadian grants. Then USAID is there, UK aid, and so many of these. So that way it is, know that we are now at the same level of any one. These are things, which actually bring research directly to what is relevant to industry. It's not like, you're dreaming about something, you get funded only when there is an industry partner and an academic partner coming together. And now the new programs, they need at least all these bilateral programs, they need an industry partner, academic partner in this country and also in the partnering country. And when that happens, you can imagine there is so much of knowledge exchange which happens and collaborations which happen.
And the relevance of problems become
it becomes very relevant because industry partner is not going to get any money. They are going to get some access to the knowledge which is generated, that's IPs and things like that. With that, we started this home healthcare program. It was called Home Sugard. And that was also another interesting thing. So people, can get their regular checkup done at home. And already in 90s or late 90s, they were already talking about non-communicable diseases as a bigger burden than communicable disease, while in India we had still communicable diseases were big. So there, NCDs and then wellness, everybody, in Germany, Netherlands, or you go to Sweden, they are all very, very fit and so on. So wellness was a very important thing. People had to go to gyms. There is no way you can, if you are a student, without showing your gym card attendance, you will not get your next card. So like that, that wellness programs, which we are talking about it now in India. They're all, in
there are so many startups in that
late 90s, we saw. And that's how, we saw the benefit of having preventive care and wellness programs. Wellness is another form of preventive care, I would say, because if you are keeping yourself fit, doing your exercise and all that, your hypertension, diabetes, everything will be in control. So that's all.
You spent a lot of time in Ericsson, the kind of projects you have described, involved a lot of research. Would you say there is a similar focus on research in Indian companies, or is it more like jugaad and let's get something to market?
I came from Stockholm and moved to Philips, and then I was the innovation manager at that innovation campus, Philips Innovation Center. So I was the first innovation manager there, and it was very amazing. And then my work was to see how we get more value for the same center, the same people and all that. Now today they may be doing some software development or some small little design or whatever. But then, can we get more value? Like you have all multinationals have their own captive center. At the same time, they also have a lot of contract with local software companies, like Philips also. They work with a lot of companies here, Wipro, TCS, and all this. So now there's always a question, in the head office that see those guys cost at least 30-40% less than the captive, and why do we need this captive centers? That sort of a thing. So there are certain things, which we need to see. In a captive center, there are a lot of things like, IPs and advanced development activity, and these sort of things, which has to be done.
So what to make and what to buy.
Yeah, exactly.
Okay.
So mundane work, life cycle management, maintenance work, all that, can be outsourced. That's all. So we had to change the profile of the entire work what we are doing. So that was my responsibility. So that was fantastic. So with the same people, I started to see how we can generate more patents, and then make it a culture. That for every 30-35 engineers, you have one patent, international patent filed every year. So that that was the benchmark we had, and that's what we could achieve by that time. After 4 years, when I took this one, we could get that. So that type of thing, and then advanced development activity. Patent won't just come like that, right? You have to. That has to be relevant to the roadmap, the futuristic roadmap of the company. So there are certain advanced development activity which happens, and that is actually like this directly coming from the CTO's office, from the CTO's budget. So what they do is they just throw the questions, problems to the first, and people have to come with some proposals. And then they evaluate the proposal, and then which are the best, they will get this money. So the success rate is 1:20 or something.
So you think someday a city like Bangalore in general can be a research hub where
It is. Today we are a research hub, and that's what that was the transformation what we had to bring in, and that today we are there. And not only that, we also make our own products. These products are basically, done here at a lower cost, means with lesser expenses and shorter lead times. So that is the new thing, and that is what we call as frugal innovation. Okay. And this frugal innovation is really, the big thing, which the world wants to learn from India. So Indians are really, we are very frugal. I made a eye testing machine. Normally, when you go to eye hospital, you see there are so many, 3-4 different equipment. They pass you through all of these. And then, one equipment will see your anterior part of the eye and see whether there's any infection or corneal disorders or there's conjunctivitis, there's the cataract, because cataract, even young people can get cataract. There are babies born with cataract. So that way, if you want to do a test, you have to rule out all this, right? So that is the first thing they do. Then they push them to another equipment where your refractive index is calculated, that is your power, myopia, hyperopia, and all that. And then, they dilate the pupil. And then they use a camera to look at the back of the eye, that is the retina. And that is imaged. And based on the image, you take certain decisions like, whether it's a diabetic retina, glaucoma, macular degeneration, all these sort of things. And then, they also look at the intraocular pressure in the eyeball.
Glaucoma.
So for glaucoma, yes. So all these, is 4-5 equipment, and dilating the pupil makes the patient wait for 2 hours.
Yes.
After that, they have to get back control. So half an hour to get the eye dilated. It is just putting 2 drops, but it will take half an hour before the pupil is dilated. And then, it takes around 2 to 3 hours before it comes back to normal. So they have to wait till that time it comes back to normal, and then only then they are allowed to go. So for anyone, it is almost a half a day's job. So we said, okay, why all this is needed? Can we not do it in one equipment? And why do we have to dilate the pupil? To see the retina behind. Today you have so much of technology. We can always see how to, we are from IIC, right? So we said, okay, let us use some way of, fooling the eye. Why do you dilate it? Because if you throw light, to take an image, you have to throw light. And once the movement, you put the light on the eye, we have double shutter here. One is our eye and the other one is the pupil. The pupil is much faster. It immediately contracts and it doesn't allow the light to get in, right? So that's why you dilate it. Like it is like giving a small anesthesia to your eye.
Oh, pupil is faster than.
Eyelid is the pupil goes very fast. It contracts. So that is why So what we said is, okay, if you don't put a light, can you still image? You have night vision cameras and all that, right? So you use a IR. So that's what I did. So with IR light, you do the entire focusing, everything, and then when you want to get the image, you throw minimum amount of light, because CCD cameras, they need minimum amount of light. They don't need very large sensor. So just put an LED light and flash, check, capture the image. I will not even know that something happened, and you are taking the image. So once you avoid this dilation process, you see your whole test can be done in few minutes. So that way, this half a day got reduced to 5 minutes. And bringing all these into one equipment and everything done through image processing. You can actually, I do refraction, I do glaucoma related tests, everything, in just
that image.
Fraction of those. And I just do the post processing on the image and I can do it. So that's how, we brought it to one equipment. And the cost of all this put together, whatever it is, 1/10 of that, we could make this. And the power what all these fellows needed, 1.2 kilowatt, I could do it in 5 watts.
5 watts?
Yeah, simple, just a webcam and some minimal lenses and LED light. So that way, it was really, made a very nice system. So that's how that device we call it as Trinetra. So that's an all-in-one eye screening device. Now this device can be taken to the field. You can take it to villages. You can take it to homes. Wherever you want, you can do that and start imaging people and remotely. We can actually add machine learning and all that and do the triaging. And say whether the person has a problem or no problem.
Okay.
If there is a problem, then you can send it to the relevant specialist. Because even though the eye is one organ for us, but in the medical there are again super specialization. For the anterior segment, 70% of the eye doctors are actually called anterior segment doctors. Then there are retina specialists. Then there are 500 glaucoma specialists. So it's a lot of super specializations there. So depending on what the machine will have identified, could be a glaucoma problem, then you send it to glaucoma specialist.
Okay.
But so you are a company that manufactures various equipment like this, and I wish through this video we can spread a little word about that also. But what is your favorite part of the innovation? Like, how do you go about the process of innovation? Is there a technique to it, or it just comes?
No, we were taught a lot of these techniques, Debano's techniques and all these things, 7 thinking hacks or whatever. But what I see is ultimately it's the most important thing is the design thinking is what is important, and we need to empathize with the problem. We need to see what is the problem. We sitting in our office or in a institute, we may not be in a position to understand what are the real problems. Like for example, I was doing this eye related thing, and initially I used to go to the camps and all that, villages, everywhere, wherever happens. I worked a lot with slums. Even now, one of my machines is in Dharavi slum. And we also have these machines on some vans which will go into other slums. And, I started to see that eye is one thing, but there is the diabetes is a very, very big problem. I think, today we say that 2 out of 10 are diabetic, any age you take. So it's a huge problem. For above 40, if you take 2 out of 5 are diabetic. And one knows that he or she is diabetic, and the other fellow don't even know that they are diabetic. That is the WHO one, what we see.
This is in India or
Across the globe. Across the globe. Maybe in few countries it's much better because they have to get the test done because of the social security and all that. Otherwise, they will not be eligible for any reimbursement. But in other countries, where it is volunteer, it's very difficult. They don't even go, and nobody want to go and get these sort of tests done and get that you have a problem. Hey, but now things are changing. Things are changing. A lot of education, people are aware. Even at the rural area, they are aware of these things, so they want to go and get it. So what we saw is the problem of eye is one type of a problem. Okay, that is diabetic retinopathy. We say that is a big problem. But the problem of kidney was much bigger. That's how while doing ophthalmology I ended up getting to start making something in nephrology.
Can you tell us?
So that is how I started with this one. And here if you see kidney, the problem with kidney is all those are diabetic or hypertensive are at the risk of getting kidney failure.
Okay.
And this kidney failure is we call it as chronic kidney disease, CKD. And it goes through in like any other disease, 5-6 stages. Till the person reaches the end stage, it's absolutely asymptotic. Absolutely asymptotic. That is the nature of this disease. Because of that, a lot of them, when they feel a little discomfort and they go to the hospital or a nephrologist, they say, sorry, it's already end stage, so you have to either get a transplant or a dialysis.
Okay.
So that is where, it was so concerning to me, and I said, well, if that is the case, can you not identify it early? That's how we started, with the early detection. So if a person is diabetic or hypertensive or both, you do a test on there are some biomarkers, like in the urine, first urine kidney started passing proteins. The smallest protein molecule among the various proteins is albumin. So at the micro millimoles, we see at less than 30 millimole, then that is the limit for a normal person. Anything above that, there is already first symptoms of kidney failure. So there is my partner, I started this company along with a nephrologist because I was interested in this, and then I found Dr. Lloyd, who was a very well-known nephrologist here. So we said, okay, he said, yeah, right, we'll do together. So we started, that's how we started. Through him, we got a lot of guidance, advice and all that. And we came up with this small little dipstick, cost around 15 rupees or 20 rupees. Just have to dip in the urine, and then we have a mobile app, which actually, you can just put that below, and then this will it will take 5 seconds, 20 seconds, whatever, and it will tell immediately whether there is a problem. If there is no problem, it is green. If there is problem, it is either amber or red. Amber means early stage, red means already stage 4, 5. So that is what we do, and this can be done by housewives or anyone. We have this health workers going in the field. They can do it. They go door to door and do the screening, all that. So that was the thing.
On the one side, you say the housewives, it's so simplified that even housewives can make.
Yes.
But on the back side, if I could ask you that, what sort of researchers and engineers sit together building something like this? So what areas of study are required for?
Exactly. See, this is see, when you are doing something, in a color based thing. So you need some dye which actually changes color when it comes in contact with the albumin protein. So we have to find a marker, a dye, which actually changes color, and at a very small quantity also it has to react. So we got some naphthalene compound, and that was something. We have with us two scientists. They are from biochemistry department. One of them is also from Institute of Science.
Okay.
She was Nirmala, Dr. Nirmala. She and then Dr. Sushumna. They are basically, one specializes in membrane technologies and all that, and the other one, in this biochemistry. So that type of people, so they come up with the compound, and then we get this done in place, which is having a minimum standard. Because these things have to be done. We need around 7 ml. I can make 1 lakh strips.
Okay.
7 ml of the dye.
Such reactivity.
So that level of dilution you have to keep on doing, and so that sort of facilities, GMP facility, is also available in Bangalore. And again our IAC person, Shyam Bhatt Biotech it is called. Dr. Shyam Bhatt is also from our IAC. And then we also have the next level. Want to have much more accurate measurement. In our case, what happens is only picking up normals and abnormals, and after that, they'll have to go to the labs, and there, those who are abnormal, they have to go there, and then they have to get the regular urine test done, and they use machine called turbidometry and all that. That does all that. Whereas, the field itself, we can also do that type of test, and that, in IAC, Pakshod. They are doing that, right?
Yes.
So I'm also one of the advisors there, and with now Kanpat and those guys. And there, that will be much more result. So now what we can do, first level we can do the screening. This will be at a very low cost. And then those who are having abnormal, that also can be done in the field.
In the low cost.
Yes. So that way we can actually go on making it more and more, mobile or at the doorstep, point of care. So that is the thing. And then now what will you do after that? Well, you come to know that that fellow has a problem. There is a need for now to motivate them so that they do some very, very basic changes in their lifestyle. Because if they are hypertensive, then they have to continue to see to it that their hypertension is managed first in a normal situation, and then they have to also take care of certain things like high potassium food. They are not supposed to eat banana. They are not supposed to take fruits. They are not supposed to drink the tender coconut, and not supposed to eat sprouted swan. And there are so many things
High protein.
which is not everyone don't know about it. Normally people think tender coconut is very good, and they may be drinking, and that's very dangerous. So for those sort of people who have chronic kidney disease, so that is another act.
Okay.
That's not a subscription model. There is a EMR. What we right from the first stage when they get the checkup done, we create an EMR. It is Aadhaar enabled,
Okay.
so that
So the Aadhaar stack is also
exactly from beginning itself Aadhaar,
Okay.
India stack behind all that, and then it will go to the next stage. The doctors know they have there is a protocol now. If it's CKD stage 1 and the person is diabetic, what they are supposed to do, stage 1 and they're hypertensive, what are their do's, don'ts, all that. So accordingly, all those things, will happen in the mobile app. So this becomes a companion for them, which will help them to manage their disease, keeping them away from the deadly process of dialysis. No, then you have the next one, that is dialysis. So for those fellows who are unlucky, or it is not easy to keep on managing your problem at an early stage. It all depends on lifestyle. It all depends on the environment. So many factors. So they end up in the end stage. We have this dialysis machine. These machines in the world. There are only Germans and Japanese. There are 2 companies. That's all. There are 4 or 5 companies who make these dialysis machines. In India, of course, we import everything. So we said, one is okay, these machines are meant to be kept in air-conditioned rooms. They are supposed to be getting good quality water, all that. And that is something which we don't get. Even in cities now, the water quality is going down like crazy. So that's where, we said, okay, can we make a machine which can be put in a low-resource setting? And that is where, we are also the doctors. We have around 1,800 nephrologists in this country, and we have more than 55 million people who have chronic kidney disease.
55 million.
Yeah. So you cannot, and then 1.5 million who need dialysis. So that is the machine specialty. Then on the power, we have power management and all that. So with a solar energy, we can run the machine. Then water, we have a patented technology. Again, Dr. Sushma works on that, and we work with Jawaharlal Nehru Center for Advanced JNCR, and we are realizing a new type of a material which actually can regenerate the spent dialysis. We say there is the 120 to 140 liters of good water is needed, RO water, less than 10 TDS.
For
one dialysis session.
Oh, okay.
For one dialysis session, it goes for 3.5-4 hours. So in this case, what we do is, once this material is done, we will pass this dialysate, which is already gone through this one, back into this. This will online clean that, and the same water is reused.
Okay.
And with less than 20 liters of water, we can do the entire dialysis.
Okay.
So then we don't need an RO plant and all that. We can actually use, make this wherever there is good water available, 20 liter or less, 20 liter can, yeah. So we can make that, seal it properly, and then along with consumable that can also be shipped. So that is the idea. So that way, this is a very unique machine, and it's also a smart machine. It's IoT interface it has. It's cloud enabled and IoT interface. So when the patient is going through dialysis, it's a little process, where they take out the entire blood, it goes into the machine and comes back at least 3-4 times, it is circulated. So there are chances that they may get some palpitations or cramps and things like that. So our machine, will be in a position to monitor them online.
Okay.
And in case there is any such problem, it will immediately take an action, it will stop, give an alarm and send a message to the doctor. Senior technician, so that they can immediately reach out to this fellow, and they can actually see the entire history of the patient.
Okay.
What are the machine parameters they have set, everything on their mobile. So that way, it makes the whole process safe and connected.
Okay.
So we call it as look over the shoulder feature.
Okay.
So the nephrologist is in a position to look over the technician's shoulder and see what's happening. So that is the thing. Okay. So that way, this is a very, very sophisticated stuff, and first of its kind, I can say.
So you're actually your background in electronics, and then
Yes.
coming to computer science.
Yes.
And then the lot of management and product development and the innovation aspects as well. So, and now the community understanding as well.
Yeah.
So, was it all planned, or did you just take
Nothing was
experiences
planned.
as
It's
it
just
came?
that, as I told you, it's a design thinking. You just have to empathize with the one problem and see, what's the real need. And then that's where, I say that the research thinking helps.
Okay.
And you can always, there is nothing which is difficult or not known. We can always, Google is there to help us. Dig it out. And all these, have to be properly patented. That's where, I'm telling you, even on the regulatory side, it's almost like making a thesis. It's much more tougher than a thesis. Literature survey we have to do simulation studies, we have to, all the design, reasoning, fault analysis we have to do, document it properly, single point of failure, all that we have to check. and everything, and then, we do the test. We have to take this to some certified labs and do all the tests
Correlate
there.
with the existing
Yes.
machines
And then we take it to the human
Okay.
trial. And then in the human trial, again, you capture a lot of data. And this is always, performance analysis. You compare this machine with the world-class machine. And then the patient will be, they will be in a pseudo-random fashion. They put them on this machine, next machine, on that machine, they like that. So everything, has to be designed. It's like a research study.
Research study.
Yeah. So there is a lot of research experience which is useful in getting this. And patents. We first have to do a landscape. Now, we can always see something and develop, but that's not the thing. A lot of it may be, patented. So first level, you have to see that you are not infringing on somebody else's patent. That is the first thing. And then, like for example, these are components which we developed ourselves, because if we try to do something else, we are going to infringe.
Okay.
So it has to be something which is very different.
How do you find the reception to this? For example, made in India products, in the old days it used to be that there might be a perception that it is easier to buy a GE or some company like that, and you said Japanese and German companies also. So how do you find people responding to such high technology coming from India? Do you find a positive response?
Yeah, when the eye thing what we did, it took us 3.5 years to get the product out, to get the standardization and all that, all the things done, regulatory and all. And we started to sell that. First we were thinking that it's only India, it is India specific or something, but nothing like it. It could be applied to any part of the world. In fact, I gave a demo of this product to the US Secretary of State, that is Hillary Clinton.
Wow.
And she said, no, this is much more relevant to US, because in US we have a lot of type 1 diabetes people, small kids, obese people, they are all diabetic, and for them, regular checkup has to be done. So I see this very relevant to the US. So why don't we bring it to US? Then we got connected to University of Texas, Austin, and IC Squared Institute and all that. And now we have an office in US selling, our product there. And we are there in more than around 26 countries now with that product. So there is nothing like only India. If your product is good, it gets accepted everywhere. I mentor a company called Cyclops. They came up with a fantastic product for vertigo. And today they are already there, in 7-8 countries.
Okay.
Same thing, what you see here, on the 9th July, President Trump, came up with a new presidential rule on kidney care. And he has said that, the kidney care, we have to change this entire thing. So as per this one, he says, we have to start promoting preventive care and disease management so that, we keep the patients away from dialysis. 2, if they go to dialysis stage, we don't get them to the institutional dialysis, shift them to homes.
Okay.
All dialysis has to go to homes. And 3 says, make more kidneys available for transplant. So do early transplants and see to it that they don't go into the end stage. So the quality of life, increases. Same thing, what we have is also on a roadmap. We are going, the next product is our home hemodialysis machine.
Okay.
Technology, what you have, what we are saying for rural or whatever, becomes entirely applicable to homes.
Right.
Because in home you have a resource constrained environment. You can't expect very high quality water there at home.
Yes.
You can't expect, power to be continuously there at home. Right? And you cannot have a doctor, sitting there, for the dialysis session, right? So telenephrology and all become very relevant. So that way, if you see, all the technology what we developed for this can be packaged. Maybe, we have to miniaturize the machine, repackage it, and it becomes applicable to home dialysis. Who doesn't want a high quality at low cost? Who doesn't want? Even though they have a lot of money, people want to we'll go for it.
Yes.
Right? So that's the thing. And that is where, this frugal innovation and all that becomes important. The difference between these big multinational giants compared to the small companies is that they started at some point. And at that time, there were certain constraints. There was no LED. Or even if there was an LED, it was blue light LEDs. It was very harmful to the eye. But then things have changed. But when they started the design, they would have had halogen lamps or something, and they had to put those lamps, and then they use fiber optic and get that to the illumination point, all that. So that technology is expensive. Even though this new technology is there, they cannot throw it out.
Yes.
Because they already have installations, and there is a promise that at least 10 years I will maintain it. So you see, like that, it has a lot of legacy behind all this.
Yes.
And then you have a lot of patents. Of course, everybody, to protect their food, they have a patent. And these patents are all linked to the design what they have. The moment, you take away the fiber optic and the halogen lamps and all that, then all the patents linked to coupling it, doing a lot of filtering and all that, everything goes for a waste, right?
It's all irrelevant after that. Okay.
So that is where the cost becomes very high because they have to recover. I've seen that, even in big companies, not to name any, see, hardly, 2 to 3% of their patent portfolio is really being used in the product.
Okay.
Only 2-3%.
Max. What we see across the globe now, it is no more, like we say, the most essential things for a human being is roti, kabda, makan, right? It is no more just roti, kabda, makan. It is roti, swasthya, and then comes kabda and makan and all now. So the priority of things have changed. And health is one thing, which is really, really important for your quality of life. That people have started to realize. We earlier, we had problems. We didn't have, India, even in the, 15-20 years ago, also you could see that more than 60% of them couldn't afford 2 square meals a day. But that situation has really changed. Today, food is not a problem. Food is not at all a problem. So obviously, it shifts to the next part. Clothing, fine, that's compared to, it's not any big difference. So health is the most important thing. And in the West also, health is something which is very important. We may have different type of problems in the different countries, but ultimately all these, have an impact on the health. And also the lifestyle, the food habits, everything, has really disturbed the whole system. And that's why, people have started to now get more and more focus on wellness, healthcare, early healthcare. So that's
and lifespans increasing.
Lifespan has increased. That's another big thing. And technologies to take care of the geriatric care and all that.
Many countries are getting old without enough young people. So
not only many countries, our own country is also getting quickly into that problem.
Okay.
Yeah. So there are certain things, like one is prevention, which actually means a big gap there, because there are not many technologies or products available for preventive care. Then there is also a lot of things which are prevention is also making people fit. That is where we see lot of mobile apps and all coming out, and these apps are like involves a lot of study, and we need to understand the pattern, the lifestyle of a person, food habit, everything, and based on that come up with analytics and all that, and give them the right type of suggestions and things like that. So there is a huge opportunity there.
We find that AI is affecting many different sectors and many parts of our own life. Do you think it can impact this sector also, and specifically you said analytics and all that. So do you think there's a potential there?
Certainly. See, now when a person is going through dialysis, we really don't know. No, the kidney has so many functions. But when you are doing it, the outside in a machine, you don't know how these profiles impact the individual. So in my machine, I have patterns in that area also. We are in a position to see based on the conductivity, changes, sodium levels and all that, and also based on the blood pressure and variations, all these temperature, everything. We are in a position to model the person.
Wow.
And make a specific profile for the person. After around 100 sessions, 200 sessions, dialysis sessions have got. So now you make the therapy, the treatment personalized for that individual and precise.
Go to the level of the individual.
Exactly. So you will see that these sort of things are only possible now because of this big data, machine learning and all that. We have a very, crude way of deciding how much time, the person has to be on dialysis. We say 3 or 3.5 hours or 4 hours. Just based on the amount of extra water fluid they would have accumulated in the body. For 2 days they won't have urinated, so there is 2 kilos or 3 kilos of water or 5 kilos, depends. So based on that, the machine will give you a calculation and say this is the duration. That's all. But that may not be always true, right? It may be so many other things. So, and then when you are having a home dialysis, it's a personal dialysis machine. So the person can opt to do dialysis every day. So in that case, all these formulas go for a toss. So in such cases, we are looking at online monitoring and seeing how we can adjust the dialysis sessions based on their profile, based on how they have their condition, physical condition and all that. So there is a huge amount of learning which happens.
Do you think there's potential for, even in a company like this, a computer science student to work in this sort of area?
Certainly. It's more of computer science guys only who can do this. Of course, with a domain guidance. So what I've seen is, most of the things at least, I'm an engineer, I have very little knowledge about medicine and all that. So what we do is, anything, if we want to understand, we convert it to a model. So I try to apply that model, everything you start applying it to that model. So that way, it's not anymore a medical problem or a clinical problem, it becomes an engineering problem.
Yeah. So you translated it in that.
Exactly. So that way it is very effective. And computer science students are very good in modeling. Any physical system you can model. Okay. We used to model those big transformers and all those rectifiers, inverters, everything. And apply control algorithms on that, right? So that way it's possible to really, there's a lot of work for the engineers, I would say, and more so computer science, mechanical engineers, compared to the doctors in making such innovations.
Sir, what would you say to those students who are thinking of starting up but a little fearful of their journey?
Yeah, I think I have done that when we were very young, and at the same time after in 2010, I said enough of corporate. For now, I was 50 years at that time. I said now I have to go back and do something. That's how I said for us, for me and my community, I have to work on something on that. So that's how we got out of this comfortable jobs and started this. But what I see is for the young students, it's much more easier. They can take a chance, and now it is the opportunity not to become job seekers, but become job providers. Whatever, even though I worked in these multinational companies and all that, whatever we earned in those 20 years, 15, 20 years, we could earn much more than that in just making a few products. And so today there is an opportunity, and there is need also. And I think, going forward, we cannot just depend on the IT industries and BT industry. That we have to create more opportunities. That means that we have to get into these new sunrise sectors. Okay. So this is one area where there is a huge need and also an opportunity. And healthcare, I tell you, it's a truly multidisciplinary work. Truly multidisciplinary. We need chemical engineers, we need biotech engineers, we need biochemistry guys, we need mechanical guys, we need hydraulics, pneumatic, everything to make such a system. So even though I have just 20-25 people here, even if you take a particular field, there are only 1 or 2 guys. So that way, it's a very, very interesting and very challenging task. And really, once you get in, you will really enjoy doing it. And you are solving a real problem. You can see people. When I put my first machine, last year in the month of February, March, we did a trial on our machines. We took it to Mysore in JSS Medical College. We put 5 patients on a machine. You could see that, one patient came to me and said, "Are you going to leave it here, this machine?" I said, "Why?" He said, "This is much better, sir. I'm seeing that, I'm not getting these cramps and all that. Well, other machines, I used to get this problem."
This has this feedback loop, so...
Yeah, it is the profiling.
Profiling is...
Profiling,
yes.
yeah.
So, adjust, self-adjusting.
Yeah, exactly. Lot of it, like even ventilators, I also see that, ventilators could be anesthesia machines or could be dialysis and all that. They are all built, in the West. And that population has a totally different type of a physiology. The same you can't apply here. So, because we don't do anything here, we just take that and adapt that. That's all. So I always keep telling that, whatever be the problem, if it is our problem, only we have to solve it. Nobody else can come and solve our problem. And we have the knowledge and capability and all that. Why can't we do it? So that's what, I would challenge the younger generation. Come on, do it. And show the world, what we can do.
Not only there's a lot of technical knowledge that goes behind, but it has impact, and while doing that you enjoy.
Certainly. And when I was in Forest, when I was executive director there, and I used to see that, we had out of 50 people, I had 15 of them who had PhDs. Imagine a startup with so many PhDs. So basically what I feel is that if you want to do something really world class, innovative, and something for a serious business like this, you need to have people with different skill set. Earlier companies, I was seeing that, if somebody PhDs are there, for the entire this one, there are only 2-3 PhD. And they normally, used to keep them away because they don't mix with that sort of thing. So it's what you're trying to do. That it speaks of the level of research what you're doing in your organization, and that is something which we see. When we also saw that Motorola, when they started, almost en masse, the entire school of automation here, whoever graduated, they will all go directly to Motorola. They had I don't know, more than 80-90 people, undergraduate and that is masters and PhD guys were there. And they could achieve the world's highest quality, in just a matter of 3 years. And there's only one expat there. Josh Smith was the only person. Rest all IAC. So that sort of of impact, we can make in India if we really are, focused on something. It is a time for us to do this healthcare thing, and then see how we can make healthcare much more. Not only cost effective, it has to be accessible. We say that the 4 A's, affordability means a lot, different. Accessibility, availability, it has to be always highly available, so it doesn't go down. Most of the medical equipment, if you see, 20 to 30% of this equipment is always, in maintenance mode. Because they are all imported. So any component fails, it has to come up from outside. If we make our own machines, we can go immediately replace it. Less than 24 hours downtime. And then appropriate technology. That's the 4 A's. And I would tell the technologists and our young researchers that it is important for us, even though we come from doing some very complex, sophisticated stuff, if we have to solve a problem which doesn't need that complexity, try to solve it with as simple as simpler technology as possible. Like, for example, to do the complex eye testing of so many different things, all that we did is just took a simple webcam, put a few lenses in front of it, minimum amount of optics, and did everything, through image processing. That is what makes it cheaper, robust, low power, and availability, increases availability of this system.
It's also, sir, on that note, I would like to thank you for your time.
Thank you, guys. Very nice.
It's been very nice.
Doing great job.
You are doing great
We'll have
job.
to fly the IISc flag high. India flag very high.
Okay.